We are live.
Good evening, everyone. Welcome to the iFocus online lecture 532 on the topic of optics and refraction. The topic for today will be geometrical optics, notably prisms, the definition, notation, types, and uses. The moderator for the session today is Dr. Zain. Dr. Zain has done his MBBS from St. GS Medical College and KEM Hospital, Mumbai, and MS Ophthalmology from Karnataka Institute of Medical Sciences, Hubli. Sir is the medical director and consultant at Khate Bai Clinic and Perfect Vision Laser Center at Mumbai. Sir has done fellowship trained in phaco-refractive and advanced anterior segment surgeries from Lakshmi Eye Institute, Mumbai, and Modern Eye Institute, Salt Lake City, USA. Sir has been a prominent faculty and presenter in state, national, and international ophthalmic conferences. Sir has also played an active part in various ophthalmic bodies like UC, BUA, and MOS in the JC committee. Sir has also been recipient of multiple international awards like the ASCRS Best Video 2023 Award, ESCRS Best Video 2017 and 2024, and Best Paper at APSCRS 2019. Sir has also been the recipient of multiple national awards like YKC Pandit Best Free Paper Award at MOSCON 2020 and TP Lahane Best Free Paper Award and 2021 in 2022. Welcome, sir. I would like to now introduce the chairperson for the session, Dr. Aditi Ma'am. She is currently the founder and medical director at Krishna Netralaya and senior eye surgeon specializing in cataract, LASIK, and cornea transplant surgeries. Ma'am is also the lead cornea surgeon at Fortis Memorial Research Institute. Ma'am has done her MBBS from KEM Hospital, Mumbai with MS Ophthalmology and won the Dr. J.G. Thakur Gold Medal for the highest marks in MS Ophthalmology from MGM Indore. Ma'am has also completed numerous fellowships from reputed eye institutes specializing in cataract surgery, cornea transplant, and refractive surgeries. Ma'am has done her fellowship in cornea and anterior segment from the prestigious LVPI. Also, ma'am has the Sir Ratan Tata Fellowship in Advanced Cataract Surgery from Shankar Netralaya. Ma'am has also trained in glaucoma from Arvind Eye Hospital. Currently, ma'am is the secretary of Gurgaon Ophthalmic Society. Welcome, ma'am.
Thank you, Garvita, for the kind words. Thank you.
I would now like to introduce the speaker for the session, Dr. Piyush Bajaj sir. Sir has done his MBBS from Manipal College of Medical Sciences, DOMS from Rajiv Gandhi University, Bangalore, and DNB from Venu Eye Institute, Delhi. Sir has also completed fellowship in oculoplasty and cataract from Arvind Eye Hospital, Madurai. Currently, Sir is an associate consultant at Center for Sight, New Delhi. He has authored multiple publications in national and international journals, and Sir has also provided mentorship and surgical guidance to numerous fellows in training for cataract and multiple oculoplasty surgeries. Welcome, sir. I would now like to...
Dr. Piyush is on mute, I think, yeah.
Yes.
Yeah. Thank you, Garvita. Thank you. I'll share my slide now.
Yes, sir. Yes, sir.
My slides are visible?
Yes, they are visible.
Thank you for including me in this iFocus presentation. I'll be talking on geometric optics. That will be part 2 on prisms. Prisms, by definition, prism is a lens that deflects light and correct ophthalmic misalignments. They are basically transparent, solid, triangular, refractive mediums bordered by two planes that are inclined by finite angles. If we learn about the history facts of prisms in 1666, Isaac Newton was the first person who, Sir Isaac Newton was the first person who systematically studied the prisms and described about the dispersion of the white light into colors by a prism. Later on, Willibald Snells in 1621 formulated the famous Snell's law, which underlines the action of the prisms. In 1743, reported the use of prism for studying binocular vision, and later into ophthalmology. Initially, was first used in the 19th century for evaluating of strabismus and diplopia and understanding the fusion and suppression, which can be used and helped with the help of prism. The prism adaptation test was first used for surgical planning in mesotropia in 20th century. There is a long history for the use of prisms, and the therapeutic uses for diplopia and for convergence insufficiency and small angle strabismus came in 1960s. Fresnel prisms were the thin, flexible prisms initially used in 1960s. The therapeutic uses are still used and started in the 20th century. If I talk regarding the prism and the light has a particle and a wave characteristics. Traveling the light initially when it is incident on the incident surface of the prism, and it refracts from the or emerges out from the prism after refracting inside it usually travels from the thicker portion of the prism and it bends towards the base. If we talk regarding the characteristics, the white light passes through a prism, it separates into multiple constituent colors, and this phenomenon is called as dispersion. A prism does not usually change the vergence. It doesn't converge or diverge the rays. It doesn't magnify or minify the images. Snell's law, each prism is bound and usually follows a Snell's law that the light rays entering and leaving the prism are bent towards the base. The image is focused towards the apex of the prism. Image is usually virtual and an image that is formed, and it is usually towards the apex of the prism. If a prism has got a refractive surface and a reflecting surface, the refracting surface, the incident rays enters inside, refracts and bend towards the base. A basic idea regarding the prism, regarding the angles, different angles. If we consider this ray, that is the PE is the incident ray, EF is the emergent ray, FS is the emergent ray, and EF is the refracted ray. The normally this PF ray should be traveling in this direction, but it bends towards the base and emerges out, forming this ray. So this I is the angle of incidence of a prism. This E is the angle of emergence, or is the angle of emergence, and the deviation that forms from the natural position of the light or the natural position of this ray is called as the angle of deviation, which is really important in ophthalmology, and I'll be talking in details regarding that. Angle of deviation is usually the angular difference between the incidence and the emergent ray. The factors which can affect the deviation is through a prism is mainly the prism angle. More the prism angle, more is the deviation. Refractive medium of the prism, usually it is glass prisms or plastic prism. Glass usually have a refractive index of 1.5. Higher the refractive index, more is the bending of the light. If we talk regarding the wavelength, usually in short wavelength lights, that is the blue, deviates more than the long wavelength light, that is red, and this is termed as dispersion. Angle of incidence, deviation decreases initially, it reaches to the minimum and that increases, and this minimum is called as the angle of deviation. It depends upon the incidence light also. Surrounding medium, higher the medium refractive index, lower is the deviation, and it also the angle of deviation is also dependent on the prism orientation. If we talk regarding the power, each prism has got a particular power. We must have seen in our OPDs also that prisms have got power starting from half prism diopter, and it can reach up to 50, 60 prism diopters also. Usually half prism diopters or one or two prism diopters are available in our trial sets, and further prism diopters are usually available as loose prisms or in form of uh, prism bar sets. So what is exactly this power? One prism diopter is equal to shifting of light by 1 centimeter at 1 meter of a distance. In this diagram, if we see, the incident light usually bends by almost 10 centimeter at 1 meter of a distance. So this prism is termed as 10 prism diopters. Amount of reflection depends on the refractive index of the material and the position in which the prism is held. The image formed is virtual, erect, and it is displaced towards the apex. Power of a prism is termed in terms of prism diopters and also in terms of centroid. Prism diopter, as I already told, it is displacement of an image towards at 1 meter of a distance by 1 centimeter. Centrad, if we are taking this along an arc, it is termed as centrad. Angle of deviation. When a ray of light is passing through a prism, it is bending towards the base. And the incident light has a proper track which it should have traveled, but through a prism, it usually deviates. And this deviation is termed as angle of deviation. The angle of deviation is minimum. The angle of minimum deviation is the smallest possible angle of deviation of a prism, of a particular prism and at a particular refractive index. What happens what happens towards if a prism is placed in front of a eye? What is the response of an eye? Is I'll explain with this diagram. If a point of object has been placed in front of the right eye and a similar point is viewed from the left eye, if I bring a base out or an apex in prism, I has already told the image is usually focused or it usually deviates towards the apex, and it will be focused in a parafoveal or away from the normal fovea of our eye. The eye will move towards the image to get a focus, and this movement is towards the apex of the prism. I'll show this from a diagram, from a picture that I took from my own camera. This is one of my daughter's toy, and this is an image captured without any prism. When I brought a prism in front of the camera, you can see the deviation. The image, the almirah kept uh, on the other side of the toy was visible to me, and the movement of I had to shift my movement of I had to shift my camera or move the camera towards the apex to again visualize the toy. So this happens. This is a normal response of an eye towards a normal eye towards a prism. Now, if I talk regarding the prism position, there are basically three prism position that we should know. One is the position of minimum deviation. If the angle of incident light is equal to the refracted light, the prism is said to be in the minimum position. And usually plastic prisms are used in this position. And this is basically used in Fresnel prism when we talk regarding the Fresnel prism. Frontal position, parallel to the when a prism is placed parallel to the frontal plane or against the supraorbital margin. Prentice position is again very important in diagnosis. Glass prism should be held perpendicular to the visual axis. So in this diagram, if you can see, the eye is deviated out and the glass prisms are placed perpendicular to the visual axis. Prentice position is really important. Orientation where the line of sight is perpendicular to the first surface of the prism and only the exit surface refracts the light. This alignment gives an accurate measurement when glass prisms are used for measurement of strabismus or squint. Minimum deviation position, the light enters and exits at equal angle and usually used for plastic prisms. Frontal plane positions are when the prisms are kept parallel to the patient's face or along the supraorbital margin. And overestimation of the squint angle or overestimation of prism power will happen if these glass prisms which are calibrated in Prentice position are used in frontal position. So what happens is errors in prism positioning is base alignment. Many a times we don't know how to align a base, whether we should be aligning it base in or a base out. Decentration and improper surface use of the prism, as I told. Axis rotation can also, and oblique positioning of a prism can also give us a wrong valuation. Prism stacking. Many a times when we are examining a case of squint and we are using prisms for that examination, the maximum deviation we can examine from glass prism is 40 to 45 prism diopters. Plastic prism, we can reach up to 50 prism diopters. When we are exceeding these limits, should be combined, but never stacked. Either we should increase the prism power in the other eye. Combining prisms by 50 over 3 prism if we are combining, but they usually lead into an additive error. It happens because of the anterior Prentice position, and what we are using is the posterior parallel position of the prism. Because of that additive error, 50 plus 3 will not become 53, it will actually become 58. To minimize this error, prism should be positioned in both the eyes. For vertical and horizontal deviation, prism can be combined effectively. How to detect a prism that is available to us in a trial set, usually whenever we place over a cross, the line will be displaced, a cross line will be displaced towards the apex. Now, if I talk regarding the prism notation, you must have heard a lot of times in our OPDs that base up, base down, base in, base out prisms. Usually, we talk regarding the base of the prism, that is a thicker area of the prism, and we usually keep, or even that notation is sent to the optometrist or also to the optician for glass fittings. So, usually, we term it as base up or base down or base in and base out, or also towards the deviation. So we should always remember whenever we are checking or whenever we are prescribing, the prisms are prescribed or used in apex towards the deviation or base away from the deviations. Prisms are also used in 360-degree notations. Like in 90-degree notation is basically when they're keeping the prism in superior position. For example, in right eye, if I'm prescribing a 3-prism diopter 90 degree, it indicates basically the 3-prism diopter base at the top. 180 degree, the base is at the bottom. 270 degree inferiorly. So 180 degree, the base is in the temporal, and 270 degrees inferiorly. Different type of prism that are used basically are glass and the plastic prisms. Glass prism have a higher refractive index, allowing for a great light deviation compared to plastic, and usually used in Prentice position. Plastic are lighter, and they are preferably used in minimum angle of deviation. These glass prisms are available to us for as loose prisms, are available to us as prism bar, are available with us in trial prism set, and also in form of Maddox rods also. Diagnostic prisms are these diagnostic prism of half to 12 prism diopter are available with us in the prism set, and 50 to 60 prism power are available in loose prisms. Prism loose prisms also and prism bars, both for vertical and horizontal or both for horizontal and vertical assessment, both vertical and horizontal prism bars are available for users. Glass prisms are heavier as compared to the plastic prisms. The plastic prisms, even in thinner forms, higher uh, for higher prism powers, are usually termed as Fresnel prisms. They are thin, flexible plastic prisms and used as press-ons over the spectacle lenses. Whenever we need a higher prism power over like around 8 or 10 or more than 20 also, even 30 prism diopters can, till 40 prism diopter, we can advise, or Fresnel prisms are available till 40 prism diopters. The thickness of these prisms are basically 1 mm. It works on the principle that the power of prism is not dependent on the thickness of the prism but on the prism angle. These prisms are thinner, cosmetically acceptable, and have less aberrations, and they usually reduce the visual acuity and contrast sensitivity. Thin prisms are arranged in plastic sheets and are available from 1 prism diopter to 40 prism diopters. Now, if I talk regarding the uses of prism in ophthalmology, the uses of prism in ophthalmology are basically divided into diagnostic and therapeutic uses. This is a basic chart for use of prisms in diagnosis, investigation for binocular single vision, measurement of angle deviation, assessment of torsion, correction of deviation, and test for retinal correspondence. There are multiple tests. I'll be telling a bit about few of these tests. How are these prisms used in these conditions? Binocular single vision testing, prism reflex test, prism 4-prism diopter test, prism fusional vergence, and vergence facility. What happens? How we use a prism reflex test? A base out prism is placed before one eye and the other eye is fixating at 33 centimeters. Usually use 10 or 20 prism diopter in this. A normal binocular vision, the base out prism shifts the image temporally, inducing a diplopia. The fellow eye makes the refixation movement and BSV is confirmed. If we are putting this on a suppressed eye, there is no eye movement and suggests a suppression of the eye. Prism on a non-suppressed eye will produce only a versional movement and no fusional recovery will be seen. There is absence of a normal fusion in this case. Exophoria, the 10 prism base out prism test is usually done and it neutralizes the exophoria if fusion reserves are adequate. If the fusional vergence is weak, a patient may complain of diplopia or fail to overcome the 10 prism diopter. This also helps us in assessing the fusional reserve in case of 4 years. Similar tests in 4 prism diopters, a very common test, and we have read this as a microtropia test also in our books. Basically, the concept is same. We are keeping a 4 prism diopter base out prism, and it shifts the image, requiring the eye to move and re-establish fixation. A normal response, the eye will move under the prism. Suppression, abnormal response, there is no either movement, indicating a center suppression. Why we are using this in case of small squints or microtropia, where 20 prism or 10 prism diopter uh, will not give us a proper result, and 4 prism diopters will create a small central scotoma in case of microtropias. It can also be used to assess a binocular single vision, as similar in a way we talked about in the previous slide. It evaluates a patient's ability to have a bifoveal fixation. Fusional vergence amplitude can also be tested with the help of prisms. The fusional vergence is assess the individual's ability to maintain the normal binocular vision by measuring the strength of their eyes, alignment under stress. They are basically done with the help of prism bars or Risley prism. A fusional vergence is typically measured using prism that introduce a prismatic effect. It can cause divergence. If I'm measuring negative fusional vergence, it can cause convergence. A normal convergence at distance is 20 to 25 prism diopters. At near, it 30 to 35 prism diopters. Divergence 6 to 8 prism diopters is normal at distance, 8 to 10 for near. Any values over more than that will be helpful in diagnosing 4 years. Vergence facility. It evaluates the flexibility and speed of the eye ability to converge or diverge in response to changing demands. This is a very useful test in diagnosing BSV, binocular single vision. What a vergence facility prism is basically, as I've shown in this diagram, it has a 12 base out and a 3 base in prism, and they're alternatively used like a flipper, and we have to flip in front of one eye, and it tests how quickly and accurately a person can switch between these prisms without causing a diplopia. A normal results around 14 to 15 cycles per minute values, and any value significantly lower than can indicate a binocular vision dysfunction is there. Prism can also be used for measurement of deviations. As we have already read, like prism alternate cover test, we have to, and evaluation of these by this alternate cover test and non-line gauges, simultaneous prism cover test, Maddox Ross assessment, and Krimsky test. A bit of about these, how are the prism usually used in these tests is prism alternate cover test used to determine the precise amount of prism required to fully counteract on both manifest trapezomes and hidden folia. Test is done for both at near and distance. In case of manifest deviation, the prism may be positioned over the either the normal or the deviating eye. The eye without the prism remains fixating and typically in primary position, and the prism position is apex towards the deviation. Maddox rod test, it is usually done for heterophorias, detection of small angle strabismus, also for cyclophorias, and also in diplopia analysis. If you're keeping a Maddox rod prism, usually a isophorias, a streak is if seen normal temporal to the light, exophoria, streak nasal to the light, and we can use prisms to neutralize or bring the streak and the point source in over each other, and the amount of prism required is actually the magnitude of deviation. A double Maddox rod test is used. Basically we use two Maddox rods, one in front of each eye, and usually the fusion is broken with these two Maddox rod, and we usually see two lines which are parallel and horizontal with each other, like in this picture. If at all there is a torsional deviation or cyclotropia, one line will appear tilted, and we have to use either prisms up and down, like base up or base down, to correct this deviation, or we can rotate the Maddox rod and the amount of cyclo deviation can be seen. Now, if I talk regarding the correction of deviation, uh, initially I'll talk regarding heterophorias or in diplopias uh, to reduce the eye symptoms, like in heterophoria, where monocular occlusion reduces the control and eases the symptom. Fresnel prisms can be used to correct the angle and relieve the symptoms if caused by this heterophoria. Assessment of binocular single vision, as already discussed in the previous slide, Fresnel prism can also be used, and it can also help in diagnosing normal retinal correspondence. A manifest deviation after putting a prism may show a binocular single vision in abnormalities. Prism adaptation test is usually done prior to in cases of partially accommodative esotropia. We usually use a base out prism or an apex in prism to correct the residual esotropia. After a hypermetropia, full hypermetropic correction is given. Patient is re-evaluated after 2 to 3 weeks for a residual deviation and possible overaction. A Fresnel prism can be used, and later on surgical decision can be made after use of these prisms. Preoperative assessment and preoperative adaptation can also be used using prisms. Like prism adaptation can be tried for at least 2 weeks or 3 weeks. Assessment of sensory fusion can help. Any sensory fusion indicator like 8 deviation, 8 prism diopter deviation indicates that there is no more than 8, indicates that there is no sensory fusion. We can get to know regarding the responders, like a sensory fusion can be achieved or a peripheral fusion is present. Evaluation of retinal correspondence, a very uncommon test, but it is needed for theoretical aspect, like a 15 diopter vertical red prism is kept over the deviated eye and ARC identification. Usually an ARC, if ARC is there, it will be seen as two vertical displaced images with one red image over the white due to the deviated eye projecting onto a pseudophobia. A normal retinal correspondence with a central suppression scotoma displays two light, one vertical and one horizontal, reflecting the absence of a pseudophobia and fixation on each eye's true phobia. The clinical importance is usually the test is vital for detecting suppression and understanding the retinal correspondence. Prism can also be used to investigate the suppression areas. Prism can be move the image nasally, temporally, or vertically. And diplopia occurs when the image fall outside the suppression area. The use of prism to redirect the image into suppression zone when binocular single vision is absent. Therapeutic uses of prisms. Sorry. My slides are visible?
No, they have disappeared. I think you stopped screen share.
Sorry. Sorry for this. They're visible now?
Not yet. Yes, visible now.
Yes. So relieving prisms to support or maintain these stable. We are talking regarding therapeutic uses. So one of the therapeutic uses, prisms can be used for as relieving prism to support and maintain stable sensory motor fusion. They lessen the optical effort required as what we call as a fusion burden system by shifting the incoming light closer to the fovea and bring it in within the foveal zone. The prism strength prescribed is usually less than the measured angle. They can be used as Fresnel prism as is shown in the first picture, and also in case of accommodative esotropias where hypermetropic correction along with the prism correction is usually given. Inverse prisms. Inverse prisms are used in case of training and disruptive applications and also in cosmetic uses. The prisms are basically aligned in the same direction of the deviation. The base is aligned in the same direction of deviation, and it is used in case of managing phorias to disrupt the abnormal retinal correspondence to come into picture. It can also be used in case of cosmetic use, where to improve the cosmetic appearance of the eye. When surgical correction is not suitable or the patient is not ready for surgery and the other eye has a poor prognosis, poor visual prognosis. Yoke prisms are basically prisms of equal power and orientation are placed in front of the eyes, in front of both the eyes with the bases pointing in the same direction. They do not correct strabismus but shift the entire visual field. They can be used in neuroophthalmology as in visual field effects, in case of homonymous semianopia or quadrantopia, also in case of nystagmus to move the null point where the nystagmus dampens and to improve the head posture and visual comfort. Abnormal head posture like in torticollis in ocular palsies, and in low vision aids to help the patient with tunnel vision or hemianopia. These yoke prisms are of use. Some prisms are called as sector prisms. They are basically, the main objective is to achieve the stability of binocular single vision across multiple lines of sight for near as well as for distance. For example, if a patient is advised a 20 prism diopter for distance and he may require just a 10 prism diopter for near. So these are called as sector prisms. There is something called as rotating prisms. The technique is to alter the sensory input in case of constant strabismus, encouraging the shift of ARC to the normal retinal correspondence, where we can start with 1 week of base out prism wear and subsequently rotate it to base up or base down. The purpose is to interrupt the abnormal retinal correspondence and allow the patient to use the normal retinal correspondence. Slab of prism in case of anisometropic patient may get double vision on eye strain if the sight of line misses the spectacle center. So we can use a slab of prism or bicentric grinding. It is usually done by opticians for myopes with high myopes when there is anisometropia. Prisms have been used for amblyopia diagnosis as well as for treatments. In case of diagnosis, if we say we can employ 10 prism diopter test, a vertical 10 prism diopter base up or base down prism is kept in front of one eye, which induces vertical strabismus, allowing the fixation behavior. Spontaneous alternate fixation is where the binocular single vision or similar vision is available in both eyes. Brief fixation with delayed refixation can happen within 3 seconds, or momentary fixation. This is diagnosis of amblyopia. It can be used in cases of treatment, but rarely used. What it basically is done, a full prism correction is combined with atropinization and near vision correction with +3 diopters. It can also be used for diagnosis of malignary, where a 4 prism vertical prism diopter causes diplopia and can diagnose malignary in our day-to-day OPD. Thank you. So these were my. Thank you.
Thanks, Dr. Piyush. Very, very comprehensive. I'm sure you also have learned and read a lot while making this presentation.
Yeah.
So, Dr. Aditi, your thoughts on prisms and the presentation in general?
Yeah, so Dr. Piyush, I think you've done a great job. And I think most of these things we forget in our regular clinical practices because something which is not used very commonly. But I'm sure you have helped us understand and refresh the things that we have learned. And I'm sure it's going to add on to a better clinical care and better OPD practices for all of us. So really nice. It was very nice, especially the applications, the clinical applications, which we tend to forget, diagnosis. Again, in a busy clinic, there are sometimes so many patients, who would have some of these kind of conditions that you mentioned. So it's a great idea. Yeah. Thanks for this. It was nice.
So, I just have a few things to add. You've covered a lot on most of the applications in ophthalmology, but few things about prismatic errors, I think, which should also be known. uh, Two conditions in which prismatic error becomes important. So one is in bifocal glasses. So, when you've got bifocal glasses where the convexity is upwards, like the reading segment which is below, that typically causes the patient's image jump, because when they go from the distance to the near segment, the prismatic error causes a loss of that one particular segment, right? Because you are seeing the lower part above instead of seeing that part if you are viewing going from top to down. So that causes that is called as image jump, and it typically causes patients to fall down when they are walking from stairs. So that is one important application of prismatic error. And the second one is in your IOLs. If your IOL is very grossly decentered in the eye, uh, the prismatic error from the edge of the lens comes into play, where again you get a similar kind of image jump where the image is not properly aligned. So these are two parts of prismatic error also, which should be known, which have the similar application of the optics of prism. Also, I wanted to ask you that since you have shown so many applications specifically with respect to squint for a postgraduate student or a fellow or a general ophthalmologist, what are the practical tests that you must know if you have a prism with you? Not all the specialist tests that a squint specialist does, but if you must know these particular things, so would you like to say which are those important ones?
Like one of that will be initially I told regard the last slide I showed regarding the malignancy. Like there are multiple tests that we do, but this is the simplest. Like if you have a four prism diopter with you or a 10 prism diopter, just place in front of one of the eye and the main job will be done in your OPD. You need not send the patient back to the optometrist in that case. Second, prism bar cover test in any squint or even in our refractive cases, a normal cover uncover test, alternate cover test along with the prism test will be really helpful. In our normal, even in refractive cases, we usually get a squint opinion or we usually do a cover test. If we have a uh, if we have high hypermetropes or high myopes also, we many a times see the eye slightly exo under the glass and also a slight ESO under the glass. So even that can be helpful with that. A prism, loose prism set, if we have, or a prism bar will be helpful in prism bar cover test. So these are the two main tests I feel are really important. A general ophthalmologist should know. Secondly, in cases of like if we have a patient, the patient is really not willing for surgeries, a basic rim speed test or a just put a prism in front of the normal eye where the other eye is not very functional, the vision is very less, and patient needs some kind of a cosmetic correction in that eye. An inverse prism can be applied into the other in the non-functional eye, and it can give a small cosmetic correction. Even that can be helpful in a general ophthalmology practice.
Okay. Uh, and few other places where prisms are used is in diagnostic equipment. So
Yeah.
that is important for residents to know. Like that is a question which is asked, in fact, in exams. So the important places that you must know is that in Goldman applanation tonometry. So whenever you want to split any image into two, for a practical purpose, prisms are always used. So in Goldman appellation tonometry, you are splitting the Myers. Even in a keratometry, manual keratometry, you are splitting
Manual
the Myers.
keratometry.
So these are two important places where prisms are used for image split. And also, nowadays you have these modern automatic phoropters. So I am using one of those. So there's a very, very useful thing where prisms are used. So what they do is that the Jackson cross cylinder, instead of asking the patient whether you can see better with this image or that image, they insert a prism into the Jackson cross cylinder. So the prism shifts the image into two, and you
Image.
have the plus and minus both on the same screen that the patient can see. So this is, with modern automatic phoropters, where prism is used to split the JCC image so that you can see it simultaneously and say whether the left one is looking better or the right one. So these are
So
some
that
important
that's new to
applications.
me.
Yeah, and one more thing is also where prisms are very useful is, in something like an indirect ophthalmoscope. I mean, in the last iFocus reading, we were talking about total internal reflection. So anytime you don't want to use a 45-degree mirror, you use a right angled prism of 45 degrees, and because of total internal reflection, it will just deviate the light exactly perpendicular.
Right, exactly.
Yeah, so
Perpendicular.
we
Yeah.
have one in our indirect ophthalmoscope right in the center, which splits, which redirects the light in a perpendicular direction by total internal reflection. So that becomes useful, having a glass which can do the same thing as a oblique mirror that is done with the help of prism. So I think
Uh,
we've had a very, very nice lecture by you, and I think we've covered almost all aspects of prisms. And Dr. Aditi, would there be anything else you would like to add, or then we would just close this session?
Yeah, I think you've discussed all the remaining points very well.
Yeah.
So I think, yeah, we can call it a day. Yeah, it was nice.
Yeah, it was a good, good, very, very detailed
Very
discussion. Would
nice.
be very
Yeah.
useful. So, Dr. Garvita, over to you. We can close the session. You're on mute.
Yes, sir. It was a wonderful session. I'm sure our PG residents would benefit greatly from the session on prisms. So we don't have any supplementary questions from YouTube or Facebook. So I think yes, we can close the sessions.
Okay. Thank you. Thank you.
Thank
All
you, sir.
right.
Thank you.
Thank you, ma'am. Thank you, sir.
So,